Good afternoon and welcome to Plenary 3. Please welcome from the Cystic Fibrosis Foundation, Dr. Albert Faro, Chief Medical Officer, and Cynthia George, Senior Director of Partnerships for Sustaining Daily Care.
Hello to all of those of you joining us online and to everyone here in the auditorium. It's a true honor to welcome you here to the final plenary session of the 38th Annual North American Cystic Fibrosis Conference. Over the past few days, we've gathered to exchange ideas, share groundbreaking research, and deepen our understanding of how we can improve the lives of those living with cystic fibrosis. I sincerely hope that your time here has been both enlightening and inspiring, providing you with useful knowledge and tools you can take back to your work. But our learning journey isn't over yet. In just a moment, I will introduce our distinguished plenary speakers who will continue to inspire us with their expertise and insights. Before we move to that, I'd like to take a moment to acknowledge some truly remarkable individuals in our Care Center network. My colleague, Cindy George, will now recognize their outstanding contributions to the cystic fibrosis community. Cindy?
Good afternoon. The Cystic Fibrosis Foundation's Mary M. Kontos Care Champion Award is presented to two members of the multidisciplinary care team who have made significant contributions in the field of specialized CF care. This award honors the memory of Mary's passion for excellence and commitment to improving the lives of people with CF through exceptional care and advocacy. Of the many highly qualified nominees for this year's Kontos Award, two rose to the top. Both have long tenure in CF care and exemplify outstanding leadership locally and nationally in the CF community. Our first recipient served as a nurse coordinator before becoming the pediatric nurse practitioner in her care and clinical research at her center. Her center director describes her as a role model for her whole team, a consummate professional with devotion not only to her patients, but to the entire CF Care Center. For over 4 decades, she has participated in local and national CF Care and clinical research committees, while always keeping sight of what matters to patients and families. She has also advocated for nursing professionals in CF to have greater opportunities to contribute on a national level. And she is passionate about preparing the next generation of CF care providers, generously offering her time to teach and mentor new colleagues. One parent shared, "She is a great communicator, taking the time to share information with us, even if it meant telling us things we may not want to hear. She always has time for us, and she has this rare ability to combine her excellent clinical skills with her innate compassion." I am proud to announce that the first recipient of this year's Mary M. Kontos Award is Monica Ulles, pediatric CF practitioner and nurse manager of pulmonary research at Boston Children's Hospital and Brigham and Women's Hospital CF Center. Monica is going to come up in just a few minutes with our other recipient. Our second recipient is described as enthusiastic, passionate, and deeply dedicated to people with CF, families, fellow care team members, and really the entire CF community. In her role as program coordinator and nurse practitioner at her adult CF center for over 2 decades, she has been instrumental in fostering a cohesive team culture. Her colleagues told us that between open communication and her genuine respect for others, she fosters an environment of partnerships where everyone works together at their best. Her positive attitude and willingness to accept challenges head-on inspire those around her to do the same. She has participated in numerous CF Foundation committees, serving as the first program coordinator on the CF Foundation Center Committee. And she supports the growth of the next generation of CF healthcare professionals by mentoring program coordinators and advanced practice providers. Her leadership at her center has been a driving force for improvements to care for and with people with CF. And this has included supporting the program's Adult Advisory Council. One teammate shared that she builds these strong, trusting relationships with her patients and their families, where they feel heard and well cared for. Co-production happens at our clinic in a large part due to her encouragement. I'm proud to announce the second Miriam Kontos Award goes to Jill Fliege, nurse practitioner and program coordinator at Nebraska Medical Adult CF Program. Monica and Jill, all of us thank you for being champions of care for our community. Please join me as you already are in welcoming them on stage. Richard Mattingly Leadership and Mental Health Care Award is given by the Cystic Fibrosis each year to a member of the CF community in recognition of their leadership and commitment to the mental health and well-being of individuals with CF. This award is a tribute to the Mattingleys and their inspiring devotion to people with CF through the promotion of emotional wellness throughout the CF community. This year's recipient was nominated by her care team with support from 6 individual members of the CF community. She has demonstrated unwavering dedication to improving the mental health of children with CF for the past 14 years. Her innovative approaches to addressing mental health challenges have made significant impact on the CF community. She coaches her CF team through difficult conversations with children and families, helping them to better understand how to assess needs and provide support. As a member of the CF Foundation's Mental Health Advisory Committee, she has expanded her influence by coaching other CF care teams and has worked on numerous mental health tip sheets for CF clinicians. She is a leader, an educator, and researcher with a wonderful sense of humor appreciated by all who know her. She never lets her team forget that kids with CF are kids first, and their lives are much bigger than their disease. I'm excited to announce that this year's recipient of the Carolyn and C. Richard Mattingly Leadership and Mental Health Award goes to Dr. Mary Beth Prieur. Mary Beth is a licensed psychologist, an associate professor at the University of North Carolina at Chapel Hill. Please join me in welcoming Mary Beth to receive this award.
A A huge congratulations and thank you to our award winners. Now, I've had the privilege of reading through each nomination, and we are so blessed to have such an incredible group of dedicated and skilled individuals in the CF community. To those of you who were nominated, we see you and send a heartfelt thank you for the outstanding work you do every day. Now, today, we turn our attention to an area of cystic fibrosis care that, while often less discussed, is of an increasing importance: reproductive health. Cystic fibrosis presents unique challenges in this domain, affecting both fertility and the overall reproductive experience. I'd like to highlight a few of the key initiatives that our plenary speakers will discuss in more detail. These are efforts supported by the Foundation that are driving progress in reproductive health for people with CF at every stage of the reproductive cycle. First, a dedicated research group has formed to understand the unique interplay of sexual, reproductive, and gender health in CF. The group works to identify gaps in knowledge, determine research priorities, and develop the necessary infrastructure to move that research forward. Second, a collaboration of patients, clinicians, and researchers is focused on developing resources and advancing clinical care in the realm of reproductive health. This diverse group of experts and people with CF aims to create a more integrated approach to managing reproductive concerns in CF. Third, several pioneering studies are underway, including one to evaluate the impact of modulators in pregnant women with CF and their infants, and one to determine the clinical outcomes of being a parent on people with CF in this modulator era. These projects are testaments to the Foundation's commitment to timely, cutting-edge research and developing patient-centered solutions. As we delve into today's discussions, let us recognize the incredible efforts being made through this work and how it all intertwines. This work represents the collective drive toward a future where reproductive health in CF is not only better understood, but also more effectively managed. Now, we're so fortunate to have speaking today 3 experts in this topic: Molly Pam, Dr. Raksha Jain, and Dr. Traci Kazmerski. Molly is a graduate of Stanford University with a degree in science, technology, and society. Her curiosity and passion as a lifelong learner and a person with CF led her to become a patient researcher and advocate for women's health and cystic fibrosis. She has served on the Cystic Fibrosis Foundation's Adult Advisory Council, the Therapeutics Development Network's Protocol Review Committee, and the Cystic Fibrosis Reproductive and Sexual Health Collaborative, or CFRESH. Raksha is an adult pulmonologist and professor of internal medicine at the University of Texas Southwestern Dallas. She holds a bachelor's degree in molecular biology from the Massachusetts Institute of Technology. She received her medical degree from the University of Texas Houston Health Science Center and completed internal medicine residency training at UT Southwestern Medical Center, where she served as chief medical resident. She's the medical director of the Adult CF program and a Dedman Family Scholar in Clinical Care. Raksha is the chair of our Sexual Health, Reproduction, and Gender Research Working Group, or SHARING. Now, on a personal note, I've known Raksha since she was a fellow at Washington University in St. Louis, and I remember how disappointed we all were when she decided to go to Dallas. I'm not sure everyone at WashU has yet forgiven her. Traci is a pediatric pulmonologist and health services researcher at UPMC Children's Hospital of Pittsburgh, where she's an associate professor of pediatrics. She earned her medical degree from the University of Pittsburgh School of Medicine, where she also completed her residency and fellowship. She completed the Harvard-wide Pediatric Health Services Research Fellowship at Boston Children's Hospital and a fellowship at the Institute for Healthcare Improvement. She is the vice chair of SHARING. Now, I promised Traci, if she agreed to be a presenter at the plenary, that I would sit in the front row supporting her and waving my Pittsburgh Terrible towel. But why wait? Here we go, speakers, here we go. Please welcome to the stage Molly Pam.
Al for that kind introduction. Good afternoon, everyone, and welcome to Plenary 3. I'm going to start us off by discussing my own experience with reproductive health as a person with cystic fibrosis and the importance of community engagement in this work. First, a little bit about me. Despite my late CF diagnosis and low lung function throughout my childhood, I knew I wanted to go to college and have a career. I studied health policy at Stanford, where I spent about a quarter of my time in the hospital, but still managed to graduate on time. Then I moved across the country to live and work in New York City, where I met my husband, Adam. Adam and I traveled around the world together. There's a photo of us in Jordan and me snorkeling in Borneo. And we started to talk about what our future could look like. Adam knew he wanted kids, and I knew that I love kids, but I wasn't sure if I wanted my own. In the meantime, I found my way onto the Cystic Fibrosis Foundation Community Voice listserv, and I got an email from researchers wanting to talk to women who had experience with hormonal birth control. In 2016, I joined a focus group that eventually turned into the Cystic Fibrosis Reproductive and Sexual Health Collaborative, or CFRESH. CFRESH came together as a partnership between researchers and people with CF to brainstorm important areas of sexual and reproductive health that could be studied. These are just a few of the topics we discussed. Our key insight was that the day-to-day experiences and anxieties of CF patients are often not accessible to researchers, and that including them as full members of the research teams and not just as subjects can direct research towards the questions that are truly important to patients and caregivers. Through this work, I kept coming back to one question that was the most important to me. Should Adam and I have a child? On one of our trips, I happened to meet a maternal fetal medicine doctor, or MFM, someone who helps high-risk pregnancies. And she told me something that stuck with me. She said, I can get you through pregnancy, but I cannot chase around a toddler for you. This sparked so many questions for me. How would my health needs affect my ability to parent? Would I be around for my child's graduation? What would happen to my child if I die when they are 15 years old? How would that shape their life and my husband's life? And do I want that to be the life that they live? I wrote down all these questions and more. This screenshot is just a partial list that I made. And I started talking about my questions with Dr. Traci Kazmerski, who was one of the researchers with CFRESH at the time. Traci and I took my list and used it as an opportunity to put the values of patient-centered research into action. Just to share two examples of the work we've done together. First, we partnered on a decision aid guide to help people with CF to think through all of these family planning questions. It's called My Voice, and it's now in the process of being tested. I also worked with Traci and other researchers and two parents with CF on a photo voice project that captured what it looks like to be a parent with CF. And again, I wasn't just treated as a patient who's a figurehead in the research. Traci and the other researchers involved me and the other parents at every single step of the process. I learned how to do qualitative coding and was listed as an author on the study. At the same time, I was still dealing with my own health challenges. In 2018, I was diagnosed with a bacterial infection called non-tuberculosis mycobacterium. Over the course of the long and brutal treatment, I developed a collapsed lung, my lung function tanked, so I started the lung transplant evaluation process. I had never wanted CF to stop me from doing anything, but I realized that with my unstable health, having kids was one thing I didn't think I could do. So Adam and I made the hard decision that having kids wasn't on the table for us. Instead, we decided to move back to California to be closer to my sister and her family. I had a dream of being the aunt who lived down the block, who the kids could come to after school. And so Adam and I did just that, and we embraced being the best aunt and uncle for our nieces and nephews. Now, I'll pass the microphone to Dr. Raksha Jain, who will walk through the reproductive health research that has happened since those early days of CFRESH. But first, I want you to hear from a few more people with CF, people who have grappled with the same questions I have. Should we have children? How do we approach having children? or not having children? And what does it mean to be a parent with CF?
Hey, my name is Caleb. I'm married to my beautiful wife, Tiffany. Tiffany and I have 2 amazing kids, miracle babies. I was very open about having cystic fibrosis, and so going into our relationship, she knew that. I think it was like the second question I asked her was like, do you want kids? Knowing my situation, it was a very high probability that I couldn't conceive naturally.
My name is Erin Abay, and I've been married to my husband Mike for 11 years, and we've been together for 16. From a young age, I knew that the care and the dedication and the love that children require and deserve was something that would be difficult for me. There have been times where I have felt like CF is my child. You know, it's a responsibility that I have to carry every day. While wonderful and amazing and what a superhero parents are and should be for their kids, I knew I couldn't do it, and I knew I really didn't want to do it. Having CF was a lot, and that's what I wanted to handle.
My name is Chelsea. I have a fiance named Scott. I always expressed to him that I wanted children. And I told him, you know, the reality of it happening is slim. When I found out that Trikafta came out and, you know, there were women that were becoming pregnant, I got so much hope. I was like, oh my goodness, like this could happen for me. And I talked to my fiance. He was 100% on board.
Beautiful uterus.
I've never taken birth control before.
Tiffany and I ultimately decided to go down the IVF route just because that information we got, the fact that I could produce sperm, the fact that she didn't have any known issues with her uterus, and she wasn't a carrier of the CFTR mutation. So like, once we knew it was a possibility, then we were like all in.
I feel like a part of you is lost.
And it was a roller coaster of emotions.
You're pregnant, lady.
Happy boy waking up with your sissy.
Mike had a vasectomy about 3 years ago. It was a fast recovery. He was in and out within 30 minutes. It was just a very simple procedure for something that meant so much to us.
I had a telehealth doctor's appointment with the endocrinologist. At the end of the appointment, she's like, is there any chance that you could be pregnant? And I hung up and I thought to myself, oh crap, well, I'm late. So I was like, well, I might as well go to the store. I need to go get a test. And I held it up against the glass window and I saw 2 lines. And I freaked out. I was not on any form of birth control before Trikafta. So I have 2 little girls, Peyton and Shelby. I love waking up every morning and making the girls pancakes.
Becoming a dad has been one of the most rewarding things ever.
I'm one of the most lucky, blessed, grateful people, and a big thanks to my CF care team. The reproductive decisions that I've made for myself have made my life so fulfilling and something to where there are days that I can forget I have CF. And I never thought I could say that.
Please welcome Dr. Raksha Jain.
All right, it's great to see you all. And I want to give a big thanks to Molly, Caleb, Chelsea, and Aaron for sharing their stories with us. I think they highlighted beautifully not only the complexities, but the celebrations in sexual and reproductive health today. These are my disclosures. So I'd like to start by thanking the CF Foundation for supporting a group that came together in 2018 called the Sharing Working Group, the Sexual Health, Reproduction, and Gender Research Working Group. And this group brings together multidisciplinary physician scientists and, importantly, individuals with CF who've come together to tackle topics that we historically didn't talk about much in CF. Some of those topics being menopause, hypogonadism, sex differences, gender disparity, you name it. And I think it's important to recognize that amongst the activities that we took on, one was to actually partner with the CF Foundation's community voice and hear directly from people with CF and their families as to what was important for them, what did they want to know. And we received a survey from over 200 people. And when we ranked what some of their top priorities were, you can see that amongst the top were fertility, pregnancy, assisted reproductive technology, the effects of sex hormones, and sexual functioning. Today, I'm going to touch on a few of those topics, namely fertility and pregnancy. So just to start with fertility in females with CF. Historically, while we don't have systematic studies, it was quoted that anywhere from 30 to 40% of females struggled with infertility or subfertility. However, this data was largely in the era prior to CFTR modulators. As we've learned a little bit more about CFTR and its role in the reproductive tract of females, we have slowly learned about some of the etiologies as to why that may be occurring. I'm just going to highlight a few of those. So when you look at the expression or the relative expression of CFTR in the reproductive tract, you can see that in the cervix, there's actually quite a bit of CFTR. And because of the prevalence of CFTR in the cervical epithelium, this actually, when defective, can result in dehydrated, viscous secretions, very similar to the mucus in the lungs of somebody with CF. When you look at the expression of CFTR in the uterus, it's also prevalent here. And defective CFTR in the uterus can actually lower the pH or make it a more acidic environment than typical. This acidic environment can actually render it difficult for the sperm to be processed even when it reaches the uterus, a process called capacitation. And when that sperm can't process appropriately, it cannot fertilize an egg. So there are likely a number of reasons, but I highlight these few because these are some of the ones that actually have potential to be altered by CFTR modulators. So I just want to highlight a case, and I think Chelsea really highlighted this nicely in the video as well, but this was actually a female I take care of at my own center. She was 31 years old at the time. You can see that she was in relatively good health with a percent predicted FEV1 of 82%, a body mass index of 22, sweat chloride of 63, and CFTR mutations, as you can see. She had been trying to get pregnant for over 2 years. She saw a reproductive specialist, and as part of her workup, she underwent what was called a hysteroscopy. That's kind of like a bronchoscopy or a colonoscopy, but it's where they take a camera into the cervix and through into the uterus to examine the tissue. You can see here that what they saw was actually very thick, viscous mucus bands, as they described it, and they presumed that this was part of the reason why she was struggling to become pregnant. Interestingly, around the same time, she became eligible for CFTR modulators. So after weighing the risk and benefits of those modulators, she decided to go ahead and start ivacaftor. She described subsequently a vaginal purge, similar to the respiratory purge we've heard many of our patients describe in the past. She explained that to her CF care team, and she explained that to her reproductive specialist. So they went back in and did another hysteroscopy. And as you can see from this photo, those mucus bands nearly entirely cleared. And I'm happy to share with you, she now has a beautiful and healthy baby girl. I will also share with you that our clinic has added vaginal purge to its review of systems, in case you're interested. So with that, we've really seen this wonderful baby boom. And this is data from the CF Foundation Registry, where you can see on the y-axis the number of females between the ages of 14 and 45 that typically experience a pregnancy per year with CF. And it was relatively steady prior to 2019. Anywhere from 200 to 300 people typically experienced a pregnancy. However, ETIs, we know, came out here in the United States near the end of 2019, and since that time, we have seen nearly a doubling of those pregnancies now that have consistently been between 600 and 700. With that, while it's wonderful, there have been a few oopses here and there, and that's really led itself to some questions about what are the implications of planning versus not planning a pregnancy. So some of us, particularly members of the Sharing Working Group, came together across 11 CF centers and looked at the people who had experienced a pregnancy at our own sites. There were 226 pregnancies, and amongst those, we actually found that about 40% were unplanned. That actually is fairly similar to the general US population, but keep in mind that a large portion of this time frame was in an era a little bit prior to the widespread use of CFTR modulators. But the other thing we wanted to know is what were the implications of a planned versus an unplanned pregnancy in CF. So we divided the group into those in gray that had an unplanned pregnancy and those in black that had a planned pregnancy. And you can see we took a look at the pre versus post lung function over on the left-hand side and found that while the people with unplanned pregnancies started out with a bit of a lower lung function, they actually did not have a difference in their change of lung function relative to those who had a planned pregnancy. But when you look at pulmonary exacerbations over on the right-hand side, the story was not the same. In fact, we saw that those who had an unplanned pregnancy actually had a rise in their pulmonary exacerbations post-pregnancy relative to those who planned their pregnancy. So I think that really highlights to us that we as a group need to think about counseling our patients on this. We heard from Aaron earlier that not everybody is interested in experiencing a pregnancy. So what do we need to do? Well, this may look like a daunting slide about contraception. It's available on the CDC website, and I don't expect many people in the room to be experts on this. I do not claim to be an expert either, but I want to point out just a few things. One is that there are a variety of options. Amongst those options, some are irreversible and some are reversible. Some are more effective and some are less effective. So yes, it warrants us ensuring that our patients see someone with expertise on this, but if you're not already discussing this in clinic, I challenge you to think about doing so. And the reason is, amongst these various options that are used, here in the United States and among people with CF, one of the most commonly used forms is actually oral hormone contraceptive therapy. And when you think about that in the context of CF, there are some important things that you should consider. One, we know that there are some people with CF that are at increased risk of blood clots or have had a history of multiple blood clots. There are some oral hormone contraceptive therapies that include estrogen. Estrogen is known at times in certain settings to promote blood clotting, so this may not be the right option for that particular person. In addition, we know we use a lot of antibiotics in CF, and some of these antibiotics can have interactions with hormone contraceptive therapy. One of those examples is rifampin, a drug that we commonly use to treat non-tuberculous mycobacterium. That particular antibiotic can render hormone contraceptive much less effective, so you want your patients to know this. Third, we heard from a beautiful session yesterday afternoon that people with CF can be at risk for early bone loss and have early osteopenia and osteoporosis. There are certain contraceptives, particularly it has been shown that progestin-only based contraception, when used long-term, can be associated with early bone loss. So again, maybe not the right option in that particular setting. And finally, there's the question of CFTR modulators. Are they going to interact with hormone contraception? Well, the good news is not all of them. So in fact, ivacaftor, Tez-Iva, and ETI, elexacaftor, tezacaftor, ivacaftor, are not expected to interact with hormone contraception. However, Lumiva is. So for your patients that are still on Lumicaftor, ivacaftor, it's important to talk to them about the need to consider either an additional contraceptive form or an alternative contraceptive form. So moving a little bit into pregnancies in CF, what do we know? I know I get asked this all the time in clinic for people who are considering having a baby of what is this going to do to my health? What's it going to do to my child's health? Well, much of the data we know right now is really from data prior to the widespread use of CFTR modulators. But the good news is, in a number of epidemiologic studies, we have seen no survival disadvantage for a female who experiences a pregnancy relative to somebody who does not. However, there have been some studies that have shown more need for treatment for a pulmonary exacerbation around that time. Some have shown a decline in lung function surrounding pregnancy, and others have shown an increased risk for gestational diabetes and an increased rates of cesarean sections. When it comes to the infants, we have seen that mothers who have babies can potentially have preterm deliveries where their babies are born at less than 37 weeks. There's also some data to suggest that babies born to mothers with CF may be of lower birth weight. That's typically defined as a weight less than 2.5 kilograms, and have been shown to potentially have higher risk of congenital anomalies. However, what do we know now in the new era of CF? And thankfully, the CF Foundation is supporting a study called the MAYFLOWERS study. You heard a little bit about this from Dr. Putnam last night in the plenary. But this study stands for Maternal and Fetal Outcomes in the Era of CFTR Modulators. It's being led by myself and my colleague, Dr. Jennifer Taylor-Kauser from National Jewish Health. And this is the first prospective study in CF to be undertaken. It's a multi-center study of over 40 sites, so thank you for those of you in the audience that are contributing. And the aims are multifold. One is to understand the impact of pregnancy on maternal health, things such as lung function, things such as weight, and importantly, even the impact on mental health. In addition, we're going to be looking at obstetrical outcomes, such as how much cesarean sections are used, what are the birth outcomes in these babies, and not even the birth outcomes just when they're born, but these babies are going to actually be followed for up to 2 years to really understand, are they reaching their developmental milestones over time, et cetera. And finally, there's 2 important sub-studies as part of the MAYFLOWERS sub-study. One of those is a pharmacokinetic study that's really going to take a deep dive into understanding ETI levels in the mother while pregnant, in the baby at birth, and after delivery, as well as in breast milk. And finally, there is a sub-study on glucose control that Melissa discussed yesterday in the beautiful diabetes plenary. And that's really going to help us understand data we've never had about glucose control while pregnant and even after. So I just want to highlight a little bit of data we have. We've not yet completed the study or analyzed data, but just to give you a sense of where we are, we have actually enrolled 279 participants in this study. We're thrilled. The median age thus far is 30, but there's a wide spectrum from 17 to 41. The median percent predicted FEV1 in this population is 83, but again, a big span from the 20s to 120s, so we'll really be able to understand a little bit about the implications of that baseline lung function on outcomes. 37% have diabetes, and 12% used fertility assistance. Thus far, of the information we have on deliveries, 95% of these females have had a live birth. Of those that have had a live birth, 39% were delivered via cesarean section. This is a little bit more than what we see in the general population. And of the median weight we've seen in the babies, fortunately it's 3.2 kilograms in normal range, and median gestational age, 38, also full term. There have been some infant complications, and we're tracking these in great detail, but I just wanted to highlight a few that have been reported within the first 6 weeks of delivery at rates of greater than 10% of cases. Of those, we have seen that 20% have extended hospital stays in the NICU, 22% did experience preterm birth, and 18% a respiratory disorder. We'll hopefully have a lot more to share with you at next year's NACFC. I also want to highlight additional studies that are being done in the pregnancy space. This one is being launched in the UK and is going to be fabulous. It's called the Maternal, Infant, Reproductive, and Child Health in CF Study. It's being led by Drs. Imogen Felton and Professor Jane Davies. And not only are they going to collect some of the outcomes that I mentioned in the Mayflowers study, but they're also going to collect some really important, valuable ones that we're not collecting, including nasopharyngeal brushings in the mother, as well as lung imaging in the mother and the infant, as well as sweat chloride. So I think you're going to find that we are hopefully going to have a lot of information to share with people with CF in the coming years. So while we don't yet have data from the Mayflowers or the Matriarch study on pharmacokinetics, a lot of people have asked, is my baby going to be exposed to ETI if I continue to take that while pregnant? If so, what are the implications on my baby? And we definitely do not have all the answers yet, but I want to share with you at least a case series that was published by Beth Collins, Aaron Trimble, Charles Esters, and colleagues. And this was three mothers and their infants. They actually took a look, as to orient you a little bit on this. On the y-axis is concentrations of drugs, in blue ivacaftor, in red tezacaftor, and in green elexacaftor. They collected blood at the time of birth from the mother in the circles, from the cord blood in the squares, and from the infant in the diamonds. Over on the right-hand side, they also collected breast milk 15 days postpartum. So you can see that actually at the time of birth, in cord blood, there is relatively high expression of all three components of ETI. In fact, at levels very similar to what we saw in the maternal blood. Similarly, the infant blood had similar levels. When you look at breast milk, again, all three components were present, but at about a log lower than what we're seeing in utero. So this does tell us that, in fact, at least in this case series, yes, babies are being exposed to ETI while in utero and while being breastfed, however, at lower levels while being breastfed. So what does that mean? What do we need to counsel our patients on? Well, again, we have a lot to understand in this space, but I just want to highlight a few points, and these are clinical considerations available on the CF Foundation website. One of those relates to the liver. We know that ETI is metabolized in the liver. And there have been some reports of early signs of liver stress in these babies. Fortunately, it's been mild. It's been typically elevated transaminases or bilirubin, and usually it's been temporary. But as a result, we have some recommendations to consider talking to those mothers about having their baby's liver function tested within a month of birth and every 3 months thereafter if that mother continues to breastfeed while on ETI. Other things to consider are eye screening. There have been data, particularly in juvenile rats who are exposed to ivacaftor, that 70 to 35 days after birth, those juvenile rats, some of them were noted to develop cataracts. So now, in ivacaftor-containing products, we recommend that you at least talk to those mothers about considering having their baby's eyes examined within 3 months of birth, and consider repeating that eye exam potentially yearly if there's ongoing exposure to ETI while being breastfed. Other things that have really challenged us as a community are what's the impact of ETI exposure in utero on our newborn screening. And this is a really great case that Dr. Chris Fortner and colleagues presented, where it's a female that they were following with CF, F508 homozygous, who conceived with a male who is an F508 del carrier. She started ETI 6 weeks after becoming pregnant, and fortunately, they had a baby girl who was born at 39 weeks, normal weight, no meconium ileus, and no pulmonary findings. When you look at that baby's newborn screening, which is typically IRT, immunoreactive trypsinogen, a marker of pancreatic function, you can see that baby's IRT was in normal range. In addition, they sent off a fecal elastase, which is a measure also of pancreatic function, and that fecal elastase was normal. That baby's liver function was tested, also normal, other than a slightly elevated indirect bilirubin. However, when you look at that baby's sweat testing and that baby's CFTR mutation testing, in fact, that baby had a positive sweat test at 60 and 67 and was found to have CF, with being delta F508 homozygous. So it's really going to challenge us as a community as to how adult CF centers, pediatric centers, pediatricians, and the state newborn screening programs need to partner together to ensure that we're not missing any of these babies. So in other scenarios, there have been reports of even more complex circumstances of babies who've been exposed to ETI in utero, resulting in resolution of meconium ileus in utero. Phenomenal and fascinating. But again, very, very complex. You look at the variety of scenarios in which that can occur, and we have so much to learn about this. Fortunately, the CF Foundation is sponsoring a workshop this November, being chaired by Dr. Jennifer Taylor-Kauser and Dr. Sylvia St-Peteri at Medical University of South Carolina. This workshop is called the PROTECT Workshop. It stands for Prenatal Modulator Treatment to Prevent CF Complications. And while we don't yet know what to expect, I think we realize that single case reports are not going to teach us everything we need to know. We need to come together as a community, understand what's happening, and really help counsel our patients and work through what we need to do to understand this landscape. So I want to move now a little bit into male fertility, as we heard beautifully from Caleb in the video today. So unfortunately, unlike what you heard from females, the majority of males are infertile. And this is classically due to congenital bilateral absence of the vas deferens, which we call CBAVD. And you can see in this picture that typically the sperm are made in the testes. Those sperm transit through what is normally the vas deferens. You can see when that's not present, that sperm is going to be trapped and not able to passage out. So what does that result in? Well, the good news is the majority of males with CF do make sperm, and they actually have normal sexual functioning, normal desires, but they just lack the sperm in their actual ejaculate. However, very importantly, CBAVD, while it results in infertility, does not result in sterility. How do you diagnose CBAVD? Well, there's a few ways. One, physical exam. Now, I will acknowledge, as a pulmonologist, I'm not the person that you want to see for this. However, I know that there are some wonderful urologists and other people in our community that are very good at this. If you're like me, maybe you'll choose a different option, and that is you can ask your patient to provide a semen sample. In that semen sample, they can look for whether there is presence or absence of sperm. You can also order a scrotal or a transrectal ultrasound. So there's a variety of options, and again, you can partner with people who have expertise in this field. So what are the options if a male does want to have a baby that's biologically theirs? Well, the good news is there's actually a variety of options, and I've just shown a couple of those here on the screen. One is called a TASA procedure, testicular sperm extraction, and that's where a needle is actually taken into the testicle to extract the sperm. The second one below is called a TASE procedure, testicular sperm extraction, and that's where a small incision is made to take a piece of tissue out of the testicles, and in both these cases, viable sperm are retrieved, processed, and then can be implanted into their partners. Now, the good news also is these procedures tend to be relatively low risk. So classically, these males can undergo just moderate sedation and even get back to work within 20 to 48 hours of these procedures. So at that point, when you have viable processed sperm, there are also a few options. One of these is called intrauterine insemination, which we term IUI, and that's where that sperm can actually be put directly past that cervix into the uterus of their partner at the appropriate time. Other options include in vitro fertilization, which we call IVF, and this is where their partner's eggs are also retrieved. That egg and sperm are put together outside of the female body to create embryos, and the nice part about this is these embryos can be saved for use at a later time, and they can actually, in some circumstances, be tested for genetics prior to implantation. So, similar to my females that I take care of, many of the males have asked, are modulators going to correct my infertility? And unfortunately, the answer to that is really no. In an already born adult male, modulators are not expected to correct the infertility. Once that vas deferens is not present, we don't anticipate that vas deferens is going to change in any way. However, this comes back to some of the fascinating things we're seeing about in utero exposure, because there is a possibility that there may be a place where that is altered. And this was actually beautifully described in a paper by Jingshen's son, John Englehart and colleagues, using their ferret model at the University of Iowa. And here you can see that what they showed is in male ferrets that actually are wild type, meaning they have no CFTR variants, that you can see very nicely there's a clear vas deferens in these males. Then you take a CF ferret, in this case a CF ferret that is G551D homozygous. In this case, there is no vas deferens present. They can see that clearly on histologic examination. Then you take a scenario where a female ferret is given ivacaftor during pregnancy, has a male pup then, so that male baby has G551D homozygous variants, but was exposed to ivacaftor in utero. And you can see in this scenario that vas deferens is present. And actually, there have been reports, in fact, presented at NACFC last year of baby boys being born with a vas deferens after in utero exposure. So mind-blowing what we have to think about in the coming years. So I acknowledge that I have framed this discussion today making gender very binary, and I acknowledge and I support that gender is a spectrum. So with that, I do want to mention another wonderful study that the CF Foundation is supporting called the PRIDE-CF study, being led by Drs. Casey Kidd, Greg Sawicki, Traci Kazmerski, and others. And this is a study that's geared towards exploring the interplay between having CF and identifying as LGBTQIA+. If you're interested in learning more about that study, I encourage you to visit this QR code and you'll start receiving the newsletters. We're aiming to start enrolling in that study next month. So another area of exciting education that we're going to have in the coming years. I just want to conclude with a few ending takeaway points. One is, I think we've heard, sexual and reproductive health is complex, but people really want to know about it. It's important to them. We are seeing more pregnancies, and with that, we have a lot more questions, particularly about in utero exposure. We are clearly going to have some ongoing wonderful studies that will hopefully provide some information to us as a community on how to counsel people with CF, how to help them understand what to expect in an era that is more current than our historical studies. And finally, despite all the data we have to recognize that this is a very unique field, and it's important that we still practice shared decision-making in this space, because there's going to be a lot of personal choices to overlay with the data we receive. And with that, I really want to highlight that my colleague, Traci Kazmerski, is going to focus in on how we partner with the community. So I'd like to introduce my friend and colleague, Dr. Traci Kazmerski.
Thank you, Raksha, and thank you to the conference organizers for the opportunity to present today. I am so excited to be here. Now, I'm going to step back from fertility and pregnancy and think about that decision to become a parent and how we as CF care teams can support people with CF as they consider their reproductive health. These are my disclosures. Now, in the photo voice study that Molly mentioned, led by Olivia Stransky with parents with CF, one of our participants took the photo that you're seeing on the left and accompanied it with this caption: "The decision to become a parent and parenting is filled with tough choices. You must make long-term decisions while only being able to look down a small part of the road ahead." And indeed, many people with CF are facing these decisions, as nearly 4 out of 5 young people with CF say they intend to have future children. It's also really important to remember that pregnancy is not the only way to build a family. People with CF can adopt, become step-parents or foster parents, or undergo surrogacy. And as Molly highlighted, CF weighs heavily in these decisions. And what really bothered me about this list of considerations when Molly shared it with me is that we don't know the health repercussions of having a child when you have cystic fibrosis. Kids are indeed germy. And balancing caring for yourself and caring for somebody else is really, really hard. Also, the stress that CF can put on you, your partner, your support system, and your children themselves can be immense. So to further understand this interplay of parenthood and cystic fibrosis, we looked at registry data from the United Kingdom on 296 people with CF who became pregnant through their own pregnancy or their partner's pregnancy. We looked at their health in the year before becoming a parent and compared it to the first year following parenthood. Over that time, we demonstrated that they experienced a decrease in FEV1 and in body mass index, and an increase in pulmonary exacerbations. But what we also found is that if they were using a CFTR modulator, it mitigated those influences on lung function. But this is a retrospective study, and it's not without limitations. It was not done in the era of widespread CFTR modulator use. It didn't include those other paths to parenthood that I showed you, and it really only looked at short-term health outcomes. So to further investigate this, we are now conducting the HOPeCF study with the goal to determine the health impact of parenthood on people with CF in the modern era. Now, when we think about health and being a parent, there's a few things that we need to consider. First, there are things about you, your age, your sex, your socioeconomic status, the path to parenthood you choose, and the number, age, and spacing of your children. Hognes and colleagues went farther and thought about this from 3 different perspectives. First, they considered it from a sociological perspective. What is the influence of your support networks? The impact of mental health on physical health? And how does being a parent align with society's expectations that you do so? Secondly, we know on a cellular level that parenthood evolutionarily carries aging impacts. And then finally, biomedically, there are hormonal changes that are associated with pregnancy, childbirth, and lactation. Children can be a source of stress and a source of infection, but they can also be a source of joy and a motivation for healthy behaviors. For example, I went running yesterday because I was anxious to be up here today, but also I want to preserve my cardiovascular health for my 2 sons who are sitting in the front row. All of these things play together and influence parental health. But what we don't understand, and what we need to, is what happens when you overlay a chronic condition like cystic fibrosis on this picture. So in aim 1 of the HOPeCF study, we have enrolled 246 people with CF who became a parent from 2012 to 2022. And we've also enrolled 717 non-parents with CF. We're going to look at our participants' CF Foundation registry data and couple it with data on if, when, and how they became a parent. We want to look at what happens to lung function over time, and we also want to examine these key CF health outcomes that are routinely collected in the registry. We want to understand, are there differences between parents and non-parents, mothers and fathers, birthing parents and non-birthing parents, and what is the impact of being prescribed a CFTR modulator? But this is really limited to what's in the registry, which focuses on physical health. And we know that this picture is much more complicated than this. Being a parent is further influenced by the responsibilities you hold in that role, the stress that you feel, the social support that you have, and the financial resources that are available to you, and the sleep you can get. And physical health, we know, is significantly tied to mental health, quality of life, and adherence. And there's still all those things about you. And importantly, what is the impact of using a CFTR modulator? So we are now enrolling in AIM 2 of the HOPeCF study. We're enrolling new parents with CF of children less than age 5, and we're hoping to gain information beyond what's in the registry or in the medical record. So if you or somebody that you care for fits this bill and is interested in participating and learning more, you can click on this QR code or go to this link and be directly connected to our study team. We're hoping to enroll over 150 parents with CF and follow each of them for 5 years as they age and their children grow and many enter school. So how are we doing at addressing reproductive health for people with CF? Now, my mom, who's also in the front row, has always given me this advice. You never know until you ask. So to answer that question, that's what we did. We've conducted 3 surveys with over 1,000 males and females with CF in the United States, and we asked them about their sexual and reproductive health experiences, care utilization, wants, and needs. And we found out quite a few things. Now, the first thing we found out may seem obvious because we just talked about pregnancy, but it's important. People with CF do have sex. They have sex at the same rates, with the same number of partners, and the same general age of sexual debut as their peers in the United States. But what we also found out is they're not receiving reproductive health care in the same ways. For example, of the 438 females with CF that we surveyed, aged 25 to 49, we found that they were significantly less likely to have been tested for STIs in the past year, to receive a pap smear or a pelvic exam in the past year, or to currently use contraception compared to similarly aged peers in the general US population. Even more concerning, of the 532 males with CF, ages 15 years and older that we recently surveyed, we found that only 1/3 had ever been tested for STIs. 14% ever reported receiving STI counseling. And among our participants who had more than one sexual partner in the last year, 76% reported that they never used a condom. In a Canadian study conducted by Thornton and colleagues, they found that the majority of adults with CF were unvaccinated for human papillomavirus, or HPV. Now, this is the leading cause of cervical cancer and other genital cancers and disease. And this is despite evidence demonstrating that the prevalence of and comorbidities associated with HPV for people with CF are quite high. A similar study conducted by Roussette Jablonski and colleagues in France found that among eligible children and adolescents, nearly 70% are unvaccinated for HPV. So what's driving these gaps in care? And to answer that question, we've conducted hundreds of interviews and focus groups with hundreds of people with CF. And they've told us that they want to discuss reproductive health with their CF teams, but they aren't. And some key themes came through this work, the first of which is that we as CF teams don't prioritize reproductive health. One of our participants shared this: I don't think they think about vaginas. I just think they like to think about lungs. Another participant shared how all-encompassing she felt cystic fibrosis was. I have trouble going to other doctors that aren't my CF doctor because I feel it's all really CF related. And then finally, a male participant shared how he felt when talking about reproductive health. I mean, it's a really big part of everyone's life, and there's a taboo about talking about it. It's just as important as other parts of your health that people talk about a lot more easily. And on this topic of communication, of the 500 males that we surveyed, 1/3 reported that they had never been told by anyone that they were infertile due to their cystic fibrosis. And this is increasingly important. A research participant shared this with us: we're in a very good place in CF care that we can consider reproductive health. Previously, you didn't get a chance to think about these things. You died or were in the hospital. And for many people who are eligible for, have access to, and are benefiting from CFTR modulators, there's a shift that's occurring where the influences on the lungs and GI system of CF may be shrinking, and the impact on other aspects of health, including reproductive health, may be growing. So what do people with cystic fibrosis want? Well, they've told us. They want educational resources that are associated with these topics, and they want age-appropriate routine discussions with their CF care team. And when do we begin these discussions? Well, as a pediatrician, I couldn't have said it better than a recent research participant in Gopika Ranjanikath's recent study, who said this: the conversation needs to start happening in pediatrics. I know it was something that I was thinking about before I even had my first boyfriend, and years before I was sexually active or even thinking about having children. It was still playing into my long-term decision-making. So when we think about improving this aspect of care, we can think about interventions focused on the patient, the provider, and the healthcare system itself. Let's go through some examples of each of these, and we'll start with some patient-facing interventions and education. Now, for teens and young adults, my mentor Greg Sawicki and I partnered with the Boston Children's Hospital Center for Young Women's Health, and we created 13 CF-specific reproductive health guides that are directly available online to people with CF and their families, as well as to care teams. Similarly, the CFresh group that Molly mentioned created reproductive health guides for adults with CF that summarized key evidence and, importantly, provided sample questions that people with CF can consider raising with their CF teams. Now, these types of resources are critical because they can level set the knowledge base of people with CF and their families on these topics, and they can also empower them to ask the questions that they need to get care. When we think about the provider, we need to take a step back and think about what provider we're talking about. In a very recent article in the Journal of Cystic Fibrosis, Simonette Bisson and colleagues said this: medical specializations divide the body up with less focus on the whole. And it's true, as a pulmonologist, I was trained to focus on the lungs, and cardiologists the heart, and GI docs the gut, and reproductive health was left to obstetricians or gynecologists or maybe urologists, and to primary care providers. But what's important to remember is that in the recent Adapting CF Care survey, about 1 in 3 people with CF report that they do not have a primary care provider. A research participant in a study led by the Ladoris Lab summarized it by saying this: essentially, we're primary care physicians for our CF patients. Whether we want it or not, that's how they see us. And we as CF providers are often really good at taking on aspects of holistic care, but discussing reproductive health can be particularly intimidating. National provider surveys have shown that almost all US multidisciplinary CF providers feel that reproductive health is important and should be standardized in the CF care model. But what they also showed is a major imbalance between how important people feel these topics are to address and how often they routinely do so in practice. For example, 90% of the people that we surveyed said that pregnancy was really important to talk about with reproductive age females with CF, but only 63% self-reported that they routinely did so. And this imbalance is much more prominent among pediatric providers than our adult colleagues. So how we optimize communication is critical. And people with CF have told us how to do it. They want to talk to us without family or partners in the room, and they want CF providers to initiate these conversations. As a pediatric provider, I find this pairs well with self-visits with teens, where parents or family members are out of the room. It gives the opportunity for teens to confidentially talk about reproductive health and for us to respect their reproductive autonomy in doing so. I also want to highlight that people in general and people with CF often are not forthcoming about their reproductive goals or plans for a variety of reasons. One of our participants shared this catch-22. If I get pregnant, I'm seen as selfish for risking that my child will grow up without a mother. If I prioritize my own health, I'm seen as selfish for not choosing motherhood and choosing myself. So how we talk about this and how we respond really matters. The CF Foundation has partnered with the Academy for Communication in Healthcare and created the Partnership Enhancement Program, or PEP. This program uses relationship-centered communication skills to better establish trust, create open dialogue, or set goals by partnering between people with CF and their families and CF care teams. Now, these skills can be particularly helpful when you're talking about reproductive health. The guide that you're seeing on the screen shows how you can use PEP skills to have conversations about family planning and reproductive goals with people with CF and their families in a way that respects their choice around if, when, and how they become a parent or they become pregnant. Daniela Gardner and Erin Trimble and the rest of the Adult CF Center at the Oregon Health and Sciences University presented data here at NACFC last year where they utilized PEP skills to engage in more conversations on reproductive health with their patients. Following implementation of their program, they demonstrated a 225% increase in the number of these discussions. And last but not least, let's turn to the healthcare system. Several years ago, Roussette Jablonski implemented on-site gynecological consultation in their adult CF center and demonstrated that it led to significant increases in contraceptive use, cervical cancer screening, and access to reproductive health care. Here in the United States, Dr. Andrea Rowe and colleagues at the University of Pennsylvania created a nudge in the electronic medical record to ask 18 to 45-year-old females with CF whether they were currently sexually active and were currently using contraception. Implementation of this tool resulted in a 7-fold increase in screening for reproductive health care needs. And when I was preparing this talk, Molly reminded me of the low-tech alternative that her clinic in California has instituted, which is this. They've added 2 questions to their pre-visit form around reproductive health. Now, this is easy but critical because it signals to people with CF, even if they don't check these boxes or circle these yeses, that this is a space that you can talk about reproductive health. And it signals to CF teams that people with CF and their families want to talk about reproductive health. But when we bring this up, we have to have people to refer to. This is a picture of the new CF care model that was published this week. And you can see that sexual and reproductive health is listed as an essential consultant. But it's not just one person on that team. Sexual and reproductive health partners can include adolescent medicine, family planning, urology, urogynecology, fertility specialists, genetic counselors, and maternal fetal medicine. What's critical here is that CF teams do not need to be experts in or direct providers of reproductive health care. But we do need to be the ones to start these conversations and connect people with CF to the care that they need and want. To further support CF teams in understanding and supporting the reproductive health needs of people with CF, the CF Foundation is undergoing the creation of clinical guidance documents that you can see listed here with their expected dates of publication. Now, I'm going to end, before I turn it back to Molly, with one final quote. I use this quotation every time I talk about reproductive health and cystic fibrosis. It was told to me by a 20-year-old woman with CF when I interviewed her for a research study. It highlights why we're here, and it highlights why this is so important. She said, "It's always like you just don't talk about it. It's one of those things that's left to the side. It's like they feel it's not as important as everything else, but sometimes it is. I mean, it wasn't life or death, but it could have changed my life a lot. Thank you."
Thank you, Tracy and Raksha. It means so much to me to see the progress that we've made together since that first focus group I joined back in 2016, and how much has changed for our community since then. It's not just the improvements in treatment and care that have given me hope for the future. It's the close partnerships between people with CF, researchers, and clinicians that have fueled this work. It's how these partnerships can help our community make informed decisions about some of the most personal and meaningful choices in our lives. I'm here to close this out by sharing how my own decision-making process has evolved. Shortly after I moved to San Francisco, Trikafta was approved. I'm extremely lucky that I was able to benefit. My lung function went from 28% to 54%, which is as high as it's been in my life. I started hiking and skiing again. Still, I wasn't totally out of the CF woods. In 2021, I had a massive hemoptysis and spent a week in the ICU. I made a full recovery, but there's nothing like a near-death experience to make you rethink your life choices. So after weighing everything we'd been through, the resilience of my body and the support of my care teams, and everything we realized we still wanted out of our lives together, Adam and I decided to become parents after all. The first thing I did was talk to my care team in San Francisco about the possibility of pregnancy. They were very supportive and referred me to an MFM. Due to my medical history, the MFM advised an alternate route to parenthood. After all these discussions, we chose to pursue surrogacy. We were lucky to have it partially covered by our employer-based insurance, and after an intense multi-year journey, we welcomed our baby girl to the world in February. And I'd love to introduce her to all of you now. This is Lilah. She's healthy and thriving, just like her mom. Thank you all. Now please welcome Mike Boyle to the stage to close out our session.
Really Well, if there was ever a plenary that shows we're in a new era of cystic fibrosis, today is the day, right? Mark it down. I just want to thank the speakers for doing such a great job of leading us through this. I also want to thank everyone here for making this an amazing few days of meeting. Our hope is that you're leaving here with new knowledge, new connections, and with more inspiration than ever before to go serve people with cystic fibrosis and their families. So we look forward to seeing you next year in Seattle. Until then, though, we wanted to give you a special gift, and that is highlights of the moments that made 2024 NACFC so memorable.
Well, good afternoon.